So we're going to start now. I am going to share my screen and show something. This is the article that we are talking about. Management of prosthetic joint infection following total knee arthroplasty with an articulating antibiotic knee spacer and early experience. We have the pleasure of having Kris Alden, who MD, PhD. Was that PhD in art history? What was that PhD in, Kris?
My PhD, believe it or not, was in biophysics. So I did that during med school. So I did 2 years of med school, 4 years of PhD, and then 2 years of med school. So
wow.
I actually was really wanted to go down the basic science route, and then residency kind of beat that out of me. So now I'm just
yeah, I get it. A residency beat a lot of stuff out of a lot of us, but much to the pleasure of clinical medicine in Chicago, you chose to go that route because we know you are a well-respected surgeon. So this is the article we'll be talking about. But I do want to point out, I went and typed in antibiotic total knee spacers and looked at all the images, Kris, that are out there. Okay. Some like that. Sorry. I can't find that one. I shouldn't have.
Oh, you had it. You just had it up, but.
Oh yeah, here it is. You see that picture, right?
Yeah, the hockey puck.
The hockey puck was in there. There are people who kind of invented their own, made some. This one I like. Some people made their own. This is an article. I just want to point this out. These are heavy hitters. Keith Fehring, Brian Springer, some really good surgeons, good people. And they literally spent the effort, and I really mean effort, of taking a implant that exists, coating it all around, taking a polyethylene and drilling Steinman pins through it. This is 2020. This is not ancient history. Okay. Yeah. Or at least it might have been, knowing most publications, it was accepted in 2015 and eventually published in 2020. And this is what they got. Okay. And I can, compare that in a sense to what you have done. So tell me a bit about your journey in infections and choosing this method of articulating antibiotic spacers.
Sure. So, I finished my fellowship in 2008 and then came to Chicago, and, being in a competitive urban market, the only thing that I really did for the first 2 years was infected joints. So when I took my board exam, part 2 in 2010, my number one ICD-9 code was 996.66. And I swear to God. And the board examiner asked me if, he thought they were all my infections. Like I just had 200 joint infections in the last, 12 months. I'm like, no, they're from all over, blah, blah, blah. Anyways, so I did every spacer out there. I made my own. I did static spacers. With all due respect to the, authors of that journal article, I kind of don't understand why you would put metal, back into an infected joint. So I'm sort of a purist. I think if you're going to put metal back in, in the setting of infection, then you may as well try to do a one stage. And I understand how people can coat prostheses with antibiotics and all that. But anyway, so I started doing every spacer that was out there, and really, just loved the OsteoRemedy spacer and had a lot of great success with it, both on the hip side as well as the knee. And I felt the patient outcomes were excellent. People got their motion back. People walked on it. I had people fully weight bear on both the hip and the knee for the duration of the time that they had their spacer in. So, it really came down to just, kind of whatever came in the door, and that was mostly infection type, surgeries. And so that was kind of what I did for the first 2 years, and it kind of hasn't stopped.
Well, I do have to say, in sharing my screen here, in looking at your, when I saw early results, I expected to see, 6 patients. Yeah. And this is 30 patients. And I was saying, like, wow, can you please move to New York so we can send you these patients? I say, I'm wondering, if Matt Barber or Richard Southgate would send you their infections in Chicago.
I see some of Matt's posts on LinkedIn, so I'm sure he's got plenty of inspections to do down in Texas. So,
Alabama. Come on,
south of the Mason-Dixon line. So
that is true. What did, from the results point of view, we have a lot of trouble in the South Bronx with infections. I mean, we have a high comorbidity population, a lot of malnutrition, a lot of obesity. You've gotten some superb results from this. What is your overall protocol? When someone comes in with suspected prosthetic joint infection. Well, you got to send them through a rigid protocol, and you're getting such good. Your results are so superior to so many others I've seen, and I know it's everything. Especially, and I'll talk about the spacer later because I did some research on it myself for quite a number of months, and I'm very impressed with the spacer itself. But what's your protocol when someone walks into the door, had a joint replacement, crossed town with Dr. Kirschenbaum, and once again got infected? Standard Kirschenbaum result, no problem. So what's your protocol?
Well, so basically, anyone that comes in with pain after a joint replacement, that's, obviously like infection, loosening, malalignment. Those are sort of my first 3 things. So I rule everybody out for infection. So if they have, high ESR, CRP, IL-6, any kind of inflammatory markers, I'll aspirate. And there's been patients where they've got high inflammatory markers, but a negative aspiration, and I will re-aspirate those patients. Even so, in the setting of, I think it's basically 20 to 25% of infections, we never really grow anything. So there's probably a lot more infections out there. We just don't have the capacity to diagnose them. But in general, someone comes in with pain, for example, in the knee, and they have some, loosening under their tibial base plate. It can be fairly pathognomonic for an infected joint. And it's just kind of figuring out what bacteria is the, primary cause for the infection. And sometimes that can be a little difficult to figure out. If barring a negative aspirate and elevated inflammatory markers, I'll still go ahead and proceed with a spacer, and then obviously take cultures intraoperatively and, send frozen section to, determine whether or not infection's present. And generally that's somewhat obvious based on the, path and the frozen section. So generally pain after a joint replacement, and then elevated inflammatory markers, and then trying to figure out what infection is present in the knee.
Do you use Cynosure?
You
can't use it in New York for some reason. It's not. So in New York.
I started this this paper before Cynosure came out, but I think that was that might have been like probably 8 years ago that Synovusure came out. I started using it then. And then I've actually gone on to also use some of the DNA, like microgenics, which is like a DNA based protocol. So I've actually had some success with that in some cases where it's I don't grow any bacteria, but I've actually found Morganella in a patient who I had suspected had a infected total knee, elevated inflammatory markers, and multiple negative aspirates, and then microgenics was able to determine that there was Morganella in the knee. So I've gone on to utilize those DNA based tests in addition to just regular aspirates.
Does anyone do anything different? I'm just going to ask a bit of the audience. Matt, do you do anything different? This is about your standard as well. I don't know if I got Matt still on. Oh, there you are, Matt. Matt Barber, is this kind of your protocol as well?
Hey, yeah, there we go. Sorry, I was still muted. Yeah, very typical. I've not, I'm going to have to look microgenics up now, but inflammatory markers, aspirate, Synovusure definitely in the mix for that as well. So that's sounds familiar.
Right. And Richard Southgate, what is this about your protocol? Send it down the line.
Yeah, I think the main thing for me, I used to Synovusure everybody when I started in 2017. Now I sort of have moved away to doing that only if things are unclear. I had a couple, I think, false positive Synovusures with the spacers in place, and you kind of don't know what to do with that information.
Very interesting.
It can be a very difficult problem to figure out when you've done a spacer and they still have persistent elevated inflammatory markers. That can be a very perplexing problem.
So Chris,
yeah, I use it as a tiebreaker mostly in those situations if I'm unsure.
Yes, I've actually had a patient who had persistent inflammatory markers. It turns out he had some type of rare cancer, which can cause elevated inflammatory markers. So he had an infected knee, and then over time, and then he eventually actually got treated. So actually, I took his spacer out and put another spacer in. He still had persistent markers, and during his time in the hospital, they figured out that he had some type of I think it was some type of lymphoma, but they treated him and he's fine and his infection went away. So I think they were probably related, the lymphoma and the infection, because it probably suppressed his immune system.
let me ask you a question. What do you think about when do you intervene on the persistent drainage? The earlier ones, or less than 3 months, who, they always ask these questions on the boards. They always ask these questions on the self-assessment exam. Person has persistent drainage at 5 weeks. They've had 2 washouts. Chris, what do you do?
Yeah, so drainage, I dive on that right away. So I don't let people drain. And I had somebody come in. So drainage, after 5 weeks, by definition, in my mind, is deep prosthetic infection. So I will basically tell that person they have deep infection and need a resection, and generally a 2-stage resection, arthroplasty, and spacer placement. So drainage, in my mind, I'm just super aggressive about it. If someone's draining even a couple days after their procedure, I wouldn't say I'm doing a full washout or anything like that, but I do make sure that wound is basically 100% sealed up.
Right.
So if they're draining, then, it's basically kind of an emergency in my mind.
Interesting. So let's switch to the spacer itself, unless somebody has anything they want to talk about. I will show you a slide that I have. Share screen, boom. Okay. I remember writing a paper in the late 1980s. Okay. I went to medical school when I was 5, Kris, so it's all right. 19, in the 1980s. And we found that the elution of antibiotics from polymethylmethacrylate was somewhat limited. We used to feather the polymethylmethacrylate to give it more surface area. Tell us about your experience on and your feeling about this particular spacer from Osteo Remedies, and the claim of the extended elution time of antibiotics. That's critical. That I think is it of all the things, the ease in making the of having it there, the modular nature. You don't have to sit there with another piece of metal. You don't have to start putting things together. But looking at the concept of the elution, have you had that in, because you kept it in around 15, 16 weeks.
Yeah, so I basically kept the spacers in, I can't remember what the average was, but, right around, around 3 months, I would start testing people. So, 6 weeks of IV antibiotics, a 4-week antibiotic holiday, and then I would start checking inflammatory markers and then potentially getting them ready for the second stage. But as far as elution goes, I think, we would put in massive amounts of antibiotics into, cement when I was doing static spacers. We'd use 4 bags of, cement to fill up the knee joint. And, we'd put just ungodly amounts of antibiotics. It's just thousands of dollars. I mean, the antibiotics themselves, are almost thousands of dollars. So we're putting in all this antibiotics, and a majority of it, a vast majority of it, would never leave the cement. So there would be some elution, minimal elution, but we would kind of fool ourselves into thinking we're going to tailor the antibiotics to the specific bacteria. But the reality is a majority of it just stayed inside the cement. So, I would basically, look at this spacer as a less expensive way to treat the underlying infection. And then obviously you can put in, beads or, powdered Vanco or whatever antibiotic you specifically want, or antifungal for that matter, and you can tailor the antibiotics to the specific bacteria. But obviously you get the upside of, much lower cost than in a big static spacer with, thousands of dollars of antibiotics. And you get obviously excellent elution of gentamicin. So, I thought of as sort of the best of both worlds. You get, excellent elution, and you also get a lower cost. And then obviously all the benefits of, being off the shelf. It's modular. It's, you're not sitting around waiting for the, cement spacer that you make and mold to harden, and so you just have it there, and it makes for a very quick, easy, resection.
Right. I'll show this other picture, which I found on their website, but 6-month elution. I mean, that is very impressive technology to me. I mean, like I said, it's actually my second paper I ever wrote was on elution of antibiotics from cement, how crappy it was. Right.
Yeah.
Yeah.
And there were I think a majority of the patients had their spacers in for much longer than, I think the shortest one was basically around 15 weeks was the shortest, and the longest that I had the spacer in was over 2 years. And but most people were in that sort of 6-month range, and I did leave it in, basically to optimize people. Maybe they had poorly controlled diabetes or some other medical comorbidity. So I would use that time where I would leave the spacer in and just let them walk on it. go see their primary care doctor, give them time to get their hemoglobin up, and obviously control whatever medical comorbidities, could be modified to optimize them for the second stage. So I was very happy to leave spacers in. The one patient that had the spacer in for 2 years, she was actually an IV drug abuser that someone in Chicago did a total knee on, and obviously she infected, and she used that time to get treated for her addiction and also get her diabetes and cardiac issues under control. So I basically told her, you get a pass on this. And now it was sort of, it was kind of a blessing for her because she kind of got her life straightened out. So I was in no hurry to reimplant people.
Yeah.
With the spacer in.
I'm just curious with the audience. I'll start with Richard. You use articulating spacers, Richard?
Yes, I routinely do. My younger patients, I'm using this Osteo Remedies system, but most of my patients are older. So I've gravitated a little bit more towards the metal on polyethylene and do a better cement job and plan on keeping them in. But I think that there's obviously some of those theoretical downsides of kind of maybe having glycocalyx reform on your spacer. That I think that's why for my younger patients, I definitely try to do more of a true 2-stage like this.
Now, Matt, I can't imagine any of your joints getting infected, but if they did, tell
If
me.
they did, theoretically, yeah.
Yeah.
No, overwhelmingly articulated spacers, static spacers are just much more unpleasant for everyone involved. I think the only scenarios where I would do anything static is if I really had a soft tissue problem, either with skin or with extensor mechanism or something that I was trying to protect and didn't trust the patient. And I've done, prefab, I've done Osteo Remedies, I've done some other moldable articulated spacers as well. Much prefer that.
Well, it's good. Now Kris, we're gonna at 30 minutes, about 3 minutes from now, Osteo Remedies is our sponsor tonight, but we'll give them the floor in about 2 or 3 minutes. But maybe you can tell me a little bit, have any of these articulating spacers fractured? Because that was always the problem I used to have with our preform, our prefab. We'd put a Steinman pin in, we'd mold a bulb syringe for a head, for a femur.
Right.
And
it's
they,
kind of everything.
Yeah, we did everything we possibly could, and we thought we were creative as hell. We really did. We thought we were creative as hell. So, any fractures? What are some of the complications you've seen?
So, there's like Matt said, it's a lot of it is related to the soft tissues and what kind of bone loss you're dealing with. So, if there's substantial bone loss and any type of ligament deficiency, then I will use a static spacer in those patients. If the soft tissues are reasonable and they don't need a flap, or their extensor mechanism is intact or in good shape, then I will do an articulating spacer. The complications I had related to this series was I did have one patient where the femur basically kind of dislodged, and I had to go back in, and that was probably related to my poor cement technique rather than anything else. I did have, and I let everybody weight bear as tolerate. And I know, they probably wanted more protective weight bearing, but I let people walk on them fully without any concerns. I told people just walk on them because I felt like, it was better for their overall physiology to be walking and weight bearing than, in a wheelchair where they'd have, disuse osteopenia and basic muscle atrophy. So I told everybody just walk as much as possible. So I did have one fracture, and basically I kind of left. I saw it on the x-ray and I just basically left it alone. And then at the time of the 2-stage, I basically took this, the tibial component out that had fractured, and, did a 2-stage, did the 2nd stage of the reimplantation. So I would say we did not have any more or less complications than any other study. We did have, obviously issues like everybody's going to have when you deal with these types of patients. They're complicated, they're sick, they've got poor, soft tissues, bone loss. So you're dealing with sort of the worst of the worst situations. But as far as problems with the spacer themselves, I would say that they were very minimal. And, everybody, letting people walk on, I thought was the best case scenario. And that obviously
That's
kept
incredible.
them physically active.
Yeah. All right. I'm going to got a message from Matt Barber, had to sign off. He has some family things. I'm glad Matt was able to join us for a short period of time. I'm going to pass it over. The Journal of Orthopaedic Experience and Innovation, which we started in 2020, March 14th, exactly, the first day of the COVID lockdown. We're able to do these journal clubs because of very nice support from various companies. As it turned out that Kris's article had to do with a company. It was heavily peer reviewed, this article, and you can see the popularity. I'm going to share the screen over for about 3 to 5 minutes to the Osteo Remedies team, and they're going to tell you a little bit about their product. This is part of the journal club. So I guess Phil Ramsey, is that you or?
Yes, sir. That is me. I believe I'm able to do it from my side. So
Yep,
let me pull this up. You guys are able to see my screen?
I can. Yep.
Perfect.
Yep.
Perfect. Well, first and foremost, I want to say thank you to Dr. Kirschenbaum and good evening to everybody. My name is Philip Ramsey, and I am the Sales and Marketing Manager for Osteo Remedies. I'm also joined this evening by our President and CEO, Kris Hughes, and our COO, Eric Stuckey. We would first like to say thank you to JOEI for allowing us to participate in this virtual journal club this evening. And also thank you to Dr. Alden for the work and time he put into his paper, which includes the use of the Remedy knee spacer system. For those of you who may be unfamiliar with our company, our vision at Osteo Remedies is to provide simple solutions to treat complex infection disorders. We're pleased to announce that next year will be our 10-year anniversary. And over that 10-year period, due to our company's focus, great surgeon partners who are thought leaders in the infection space, and strong distributors, we've been able to achieve market share leadership. Unlike most orthopedic implant companies, we wake up every day with the purpose to develop industry-leading products to help treat periprosthetic joint infection. 1 second here. So our product portfolio consists of the most comprehensive preformed spacer systems available on the market that offers multiple size options for the knee, hip, and shoulder. Beyond our spacers, we also provide the only dual antibiotic bone cement that has 1 gram of gentamicin and 1 gram of vancomycin per 40-gram bag, as well as a neutral pH bone void filler that comes in a resorbable B kit. 2 of the most widely used spacer systems we offer is the Remedy Stem Knee Spacer and the Remedy Spectrum GV Hip Spacer. The Remedy Stem Knee Spacer is the first and only preformed knee spacer system that allows you to attach modular stems to both the femur and the tibia. The system also includes 10 millimeter augments to compensate where bone loss is present. The Remedy Spectrum GV Hip Spacer is the only dual antibiotic preformed hip spacer system that is available on the US market that offers both gentamicin and vancomycin with an average of 4 to 5 grams of total antibiotics per construct. Another unique feature that our hip systems provide that others do not is the ability to dial in the modular femoral heads up to 17 millimeters to help adjust your offset and leg length, along with a preformed all PMMA antibiotic eluting acetabular cup that comes in multiple size options. The rationale for our spacer design is to provide a product that has all eluting components with no exposed metal or poly and allows for up to 6 months of elution as it compared to days or hours with intraoperative created spacers. The system was designed with efficiency in mind for both implantation and removal, as Dr. Alden previously reported in his paper. We feel confident that our preformed all PMMA antibiotic eluting spacers are the best option for surgeons who choose to perform a 2-stage revision, which the literature supports as the gold standard to treat periprosthetic joint infection. I hope that after tonight, everyone on this call has a better understanding of OsteoRemedy's mission to be the ongoing leader with unique products to help treat periprosthetic joint infection. And as you weigh options for managing PJI, we'd ask you to consider OsteoRemedy's unique product offering as part of your overall treatment plan. So Dr. Kirschenbaum, I don't know if there's any other questions you want me to ask, but we appreciate the opportunity, and I was going to hand it back over to you.
All right. Sounds good. Just stop your screen share for a second. Yeah, there we go. That was great. I just have a question for you. Now that I have you on screen,
Yes, sir.
what's the status of the shoulder implant? You know, you have that as well? Is it?
Yes, sir. So we have the only modular size interchangeable shoulder spacer available. That's preformed. So it has 3 humeral heads and 3 humeral stems. It also allows you to dial in the head up to 9 millimeters.
I say that because I didn't know you guys had a shoulder involved, and that's yeah, as more and more shoulders seem to be done. I think there's a virus that's coming in the Bronx that's carried by a shoulder fellowship trained surgeon. Because whenever a shoulder fellowship trained surgeon comes to town, the amount of shoulder cases go up significantly. Anyway, Phil, I want to thank you so much for that great presentation, and thank you for support of the Journal Club.
Yes, sir. Thank you.
So, Kris, let's get back. Have you ever used any of this to any of the articulating spaces for native joint infections, or you don't see that many of those?
You know, I have. I've done it on the knee.
Yeah, on the knee.
Sure. Yeah. For the hip, I think I just did a washout, and then I just washed the joint out and then brought them back and did a total hip down the road. But for the knee side, I've done the knee spacer in a native situation where there was significant arthritis. They were bone on bone, right. And I knew they would need a total knee
eventually. Yeah. So we, it's very interesting in looking at the article. I saw you use the first generation of this product, and now they have the stemmed product. Mm-hmm. Have you switched completely to the stemmed version? Because it seems that's a home run. I mean, to use standard.
Yeah, I haven't actually. The last 2 spacers that I did, which I think were like basically within the last 6 weeks, I didn't really need the stemmed components. I had good fit and fill and good fixation, so I didn't need the stability of the dowels. But obviously, one of the most important things we can do to really treat periprosthetic infection in the knee is to obviously irrigate the intramedullary canals of the femur and tibia. So I will definitely open up those canals very broadly and irrigate substantially. But I didn't feel the need to, put in dowels. I've also put in, antibiotic impregnated beads into the canals just as an extra measure.
Right. One of the challenges that I have seen in M&M rounds and just around the country going around is with spacers, with dislocating spacers. Mm-hmm. I mean, it's so, the longer they stay in, the curve of it going to dislocation on the knee is very high. Especially, we'll talk about the knee first, and the hip is even more. What's been your experience with, let's talk knee first. What's your and also I want to tell anyone, if you have any questions at all, you can put them in the chat, and I'll come and I will ask Kris or Richard Southgate or anyone else who is over here who is an expert at this. So dislocation, tell me about it, because it's I see it.
So
all.
It's a real problem, and again, I think it comes back to, patient selection. So knowing, the status of the soft tissues, knowing whether they've got a competent extensor mechanism, whether the MCL, and the MCL in my mind is the most important ligament as far as whether or not to do a static versus a mobile spacer. So, obviously, the goal is to try to do a mobile spacer first, but when there's substantial bone loss, then you're basically kind of setting the patient up for failure of that spacer. And then you're kind of at that's a terrible situation to be in for everybody, surgeon, patient, especially because you've got a sort of a partially treated infection, you've got a dislocated spacer, and then you obviously have to go back in and, fix things, do another spacer. And then obviously the main worry is the status of the extensor mechanism, because if the femoral component or tibial component should dislocate, then, the extensor mechanism is at risk. And then that's a disaster. That's a complete disaster, because you're dealing with extensor mechanism deficiency and, infection. And there's no good solution to that. So that's my main criticism of the sort of hockey puck type, when people just put a big slab of cement in and they've got, this hockey puck in. That's basically just a disaster waiting to happen. And I've also seen static spacers dislocate as well. So,
right.
They don't put sufficient sort of rebar up the femur and down the tibia, and then then the spacer can dislocate, and that's a nightmare. I feel like there's really not a great solution to that extensor mechanism deficiency and infection. Then that's just made things a lot worse. So I always try to make sure I do a very adequate, really robust cement interdigitation, so that I've got good fixation, so that the spacer doesn't dislocate.
Richard Southgate asked a great question. Are you having your second stage patients take extended oral antibiotics after replantation?
Yes, absolutely. Yeah. I will have them stay on for a minimum of 2 years of oral antibiotics after their 6 weeks are up of IVs. I just feel like, a lot of the studies will say, that they're more prone to, even a different bacterial infection after the first, they've got basically a 90% cure rate on the first go round. And then if it reinfects, then you've got a 50% cure rate. And they're obviously more prone to infection. And obviously, usually these patients are, they're sicker, they're older, they're usually, have some element of metabolic disease, like poorly controlled diabetes. So I will have patients stay on oral antibiotics for, a year to 2 years, depending on the situation.
That's we do it for a year. You kind of make it up along the way. You're not really sure. Sometimes some people do it for life. I mean, I've heard that, Yeah,
I have seen patients come in for second opinions that were treated elsewhere, and they've been on antibiotics for 5-6 years.
Yeah.
And I wonder about the prudence of that, because I think you're probably promoting bacterial resistance at that point. But I would say that, 1 to 2 years is sort of the minimum that I would want to do.
Interesting.
And then obviously, checking inflammatory markers along the way, not every 3 months, but a couple times a year, I think, depending on the patient and their specific characteristics. And
so let me ask you a question about the hip implant, because you're using that, right?
Correct.
So the number one problem I have seen with homemade remedy hip spacers has been the difficulty of getting soft tissue tensioning and getting a hip dislocation, which happen way too frequently. with antibiotic spacers. You know, I
Right.
like to say it happens minutes after implantation, but maybe it's a couple of weeks, maybe it's but it's not a good situation. Yeah. What's been your experience with this modular, the neck, the screw-on ball from Osteo Remedies, and the ability to tension it? Has that panned out?
Yeah, I've been very happy with it. You know, I think hip infections are probably a little bit, well, obviously they're more rare than knee.
Yeah.
You know, obviously, but I've never been one to sort of just do like a little washout and, you know, hope for the best and change the poly. I just feel like you're not really doing anybody a service by doing that, unless you obviously catch the infection early. So I will go and do a two-stage exchange in those patients. And I've been happy with it. You know, the hip, you know, having the different size ball and different stems and how they're modular and matchable is always a huge plus, because you can, you know, basically you've got reasonable ability to extend the head neck junction so that you can create sufficient soft tissue tension. But I think basically just having, again, depending on the bone stock in the acetabulum, but having sufficient ball size to promote stability is also a big part of it.
Well, yeah, I mean, like I said, it's such a challenge. Now, interesting, you touched on the overall cost, okay? How people don't realize this system costs a certain amount. I won't even go into that, because I you know, somewhere between $1 and $50 million. Now, you know, so this system costs a certain amount, but people who have constructed their own, from even off-the-shelf implants, cost effective, this approach, in your opinion? The Osteo Remedies approach, overall cost effective?
Yeah, I mean, so basically, if you're going to do a spacer, a full articulating cement spacer, this is the most cost-effective one out there, in my opinion. The other, so, you know, if you're going to make a static spacer, you're going to spend, you know, use 4 bags of antibiotics. They're $500 a pop. That's $2,000 there. And then you've got probably $3,000 to $4,000 worth of antibiotics. You're already in that sort of $6,000 range for a knee spacer.
Right.
So, you know,
Not including some of the metal you use underneath. Maybe you use an IM rod, a mini IM rod to span the femur and tibia, stuff that Stephen Cavo has done, you know, years ago. I'm not going to say what it's now. Yeah.
So, you know, and as far as, you know, cost effective, I think this is about as good as it gets, in my opinion. You know, you could spend thousands of dollars on antibiotics, you know, and cement, and then also OR time. You know, this is, you know, it's there, it's sizable, it's modular. You can do, you know, a resection and put the spacer in, you know, 30, 45 minutes and you're done. You know, that's better for everybody. That's better for the patient too, because they're not, you know, open. They're not, you know, on the OR table, lack of, you know, anesthesia time and OR time. So you save the system money in that respect too. So as far as the spacer goes, it's simple, it's easy, and in my opinion, it's a very reasonable expense given the complexity of the problem.
Do you stock it on the shelves? Do you have the rep bring it in each time? How does it work?
We stock it at the main hospital that I go to, they stock it, and then another one they bring it in. But it's there, so it's kind of nice. So, you know, I can basically call the OR and say, you know, we're going to do this, you know, Thursday afternoon, and it's Thursday morning. They got all the stuff there, so it's nice.
Yeah. So I got 2 questions. One bounces off of this. It's someone direct message to me. View of the patient. What would you choose? Value to the patient. Okay. Outcomes divided by cost. That's the definition of value at the Harvard Business School. So high value, that your approach, you feel? Outcomes divided by cost?
I think it's the best of both worlds. I think it's great value and great outcome. So
Yeah.
I've been very happy with it. I think it obviously you need to tailor it to the specific patient. So I have done the whole gamut. So I've done a one stage in some patients for various reasons, and obviously a two stage articulating spacer in other patients, and then a static spacer, in other patients, depending on the situation, their biology, their soft tissues, their personal situation, their medical comorbidities. So I think this fits, a nice range of patient problems, and it can solve it in an inexpensive manner that gives patients great outcomes.
So
The fact that we got 90% cure rate, I think, was a home run, in my opinion.
90% cure rates. I mean, that's almost better than a primary joint replacement in some way, when you really think about it. I mean, 90%, considering many people infect because of their comorbidities and other albumin levels and, things we don't know about, the host factors,
right?
Important things that we have to control for to get into a 90% an infected group. Is staggering.
Yeah, I think obviously, like we've come, in my opinion, we've come as far as we can, as far as, everybody's using antibiotics and, less invasive techniques and, standard, skin preparation protocols and all the things that we're doing to try to minimize, obviously room traffic and, ultraviolet light and all the, laminar flow and all the things that we're doing to minimize the risk of infection. But obviously patients are, going to be part of the problem, and, that's not changing. And we're never going to solve this problem. It's always going to be there. Bacteria, I always tell patients, bacteria were on this earth, millions of years before the first human, and they'll be here long after the last one's gone. So, it's just part of arthroplasty is dealing with infection. So yeah, I think the nice tool to have to solve a very complex and difficult problem.
One of the questions was a little bit unrelated to the actual article, but what lab tests do you do and what criteria do you hold these lab tests to prior to the second stage of the implantation? CRP,
So I'll do ESR, CRP, and interleukin 6. And if those are normal, then I won't stick a needle in the joint, because I feel like, I'm just nervous about introducing infection. They've found, synovial cell, epidermal cells inside the synovium after an aspirate. So you could always potentially introduce infection. So if their inflammatory markers are normal, their diabetes is reasonably well controlled, hemoglobin of, I try to get them below 8 in general. So once they meet those criteria and, potentially if weight loss is an issue, then I have them, get their BMI down. So if they meet those criteria, normal ESR, CRP, and IL-6, then I will, schedule them for the reimplantation, the second stage. If their inflammatory markers remain elevated, then it becomes a more complex scenario. Then it's a question of whether or not you give them more time, more antibiotics, recheck in a few months and see where, or 2 months and see where they're at, and potentially explore the possibility of doing a second, washout and spacer placement. And I have done that as well in certain patients. So try to optimize them as much as possible prior to the second stage.
So I'm just going to ask, we have only 5 minutes left, which is almost no time left. This went so fast. I want to see if does anyone have any last questions. You could speak up. I'll let that go. Otherwise, I think we covered a lot of ground. I want to refer people to the article in Joey, but hope to see a couple more of these articles. My own thing also, just on a side thing, I wonder if if future of some of these spacers from Osteo Remedies would include augmentations for bone loss. Because we take out these infected stems, and you can make it up with cement, I guess, at some point in time. But sometimes you really, need a lot more, and maybe distal augmentations in the femur. You know what I'm saying? Or single wedges on the medial or the lateral aspect, so you don't have to cut down as much. And I'm sure that's in the works. If not, someone at Osteo Remedies just took notes, and I gave a good idea away. I'm fine with that. I'm fine with that. But Kris, I want to thank you so much for the article and for spending your time with us tonight.
Absolutely. Thank you. And so great discussion.
Well, thanks. And I'm going to say good night to everybody. And I hope everyone learns a lot. Kris?
All right. Thanks so much. Thanks, everybody. Really enjoyed it.
Thanks. Bye-bye.